go on to our second speaker, Dr. VARUN KHARBANDA, who is a consultant of Nazareth Hospital, Jeevan Nidhi Eye Clinic, and Mahesh Netralaya. I really wanted to know how he is there in all the three places from Allahabad. And he has another very interesting video to show. On to you, Dr. VARUN.
Thank you, Chitra ma'am. Well, Allahabad is a small place. We take about 5 minutes to get from one place to another, so I can manage. It's an honor being amongst this august gathering. After seeing Ridhima's cases, she is my senior from Narayana, and she's always been an amazing surgeon. I've learned so much from her. My surgery is going to be a little bit of a dampener. My surgery is also about a zonular diastasis. I'm just going to start sharing my screen. It was basically aimed at the younger generation to kind of show them the mistakes that one makes while doing surgeries and how to mend them. All of my seniors here, probably it's a everyday thing for you all, but I'll still try and make it interesting. So this was a case of a young patient. A panoptic IOL was planned with an OCCI at 0-180 axis because he had about 0.75 diopter of astigmatism. Everything was going well, but as soon as I started the rhexis, you will notice that the rhexis is probably smaller than the ideal size. We being young surgeons in private practice, we tend to sometimes overcorrect and overdo in premium patients. However, the rest of the steps of the surgery went off uneventful. This is my technique of handling soft cataracts. I dissect, delineate, I make sure I rotate it nicely, and then I do a modified chop where I basically separate the endonucleus first. The delineation, dissection, and rotation actually makes it very easy to eat the epinucleus in the end for me, because that is something everyone struggles in the beginning, especially in soft cataracts. So we can see here that the small rhexis did not really hinder the phaco. It went off uneventfully. And the epinucleus also came out rather easily. So this is when you start feeling good about the surgery and you're like, the major part is over. I paused it here because I want to bring everyone's attention to the top right-hand corner of the eye, where we can see a little bit of a reflection of the phaco drape. Now, I did not realize it then, but I end up pulling the capsular bag right at the beginning. I've slowed it down so that everyone can appreciate that. This is where I pull the bag. However, when I was doing the surgery, it did not occur to me because I just kept thinking that this is a reflection of the drape. I continue the same side and I end up putting a little more of the bag towards the end. Unfortunately, even then I did not realize. Only when I switched sides did I see the capsule rolling up. And now I have realized that something wrong has happened. I can see the capsule rolling up at between 12 o'clock and 1 o'clock. I could make out that there was no vitreous loss because the pupil and the bag were undisturbed. So I decided to finish the irrigation aspiration. And again, for all the young surgeons, never take out the irrigation without injecting some visco in case of rend or a dialysis. This being a panoptics patient puts an additional pressure on you when you're in a standalone private practice. But because I was pretty sure that the dialysis is not more than 2.5 clock hours, and I had access to a CTR, I decided to go ahead. So while they were getting the CTR, I decided to do the OCCI. And this is pretty much routine, like how Ridhima had explained. I used the McPherson to introduce the CTR in the AC. And then I use the microrhexis forceps to place the CTR. I'm just going to run it up a little bit. That's it. And thankfully, everything went well. The lens was nicely centered. The patient was, I think, 6 parts in N6 on day 1, but he's happy he got the other eye done as well. That's something I always tell myself, the patient comes back for the other eye, and that means you did a good job. Yeah, that's about it, ma'am.
Yeah. Thank you very much, Dr. VARUN. That was a nice teaching video. Now, I just want, before we go on to the actuals of the surgery, I just wanted to ask Dr. Vavikar, now, when would you look at doing a toric multifocal IOL, so a small amount of astigmatism in the eye? Uh, would you have a lower limit at which you would start, Dr. Vavikar?
Yes, if the post-operative astigmatism is going to be one diopter, that is the time I start thinking of at least one diopter. That is the time I start thinking of toric monofocal or multifocal.
Isn't it against the rule or with the rule? I think if it's against the rule, I would look at even smaller amount of astigmatism to start off with. If it is with the rule for one, yes, I would wait.
Yeah, madam, actually what happens is that not every patient progresses in the against the rule manner with age. There are a lot of patients who don't progress at all. If you see the percentage, it is very difficult to decide what to do. We had developed a nomogram, like for every 10 years, the astigmatism increases by 0.34, but it does not work that way. So it is correct to, undercorrect ATR. That's all. But I would still stick to one diopter astigmatism.
One diopter is what we also generally were taught.
What is important is that, second post-op day, if the patient is 6'6", patient is happy. After 10-15 years, he develops slight astigmatism. It is pardonable.
Swapna, what are your thoughts about so much of hydrodelineation in a routine phaco case? Besides the pros, which Dr. Varun was trying to say, are there any cons to doing multiple hydrodelineation in a soft cataract?
Rather than that, because there's already a pre-existing zonulodialysis, I would be a bit wary of using the amount of fluid inside.
This was intraoperative. Sorry to interrupt.
Oh, okay. So it happened only because you pulled the capsule?
Yes, that's what I was trying to show.
Yeah, fine. Then it's okay. But another way of handling the soft cataract could be to do, I don't quite understand why do you want to leave the epinucleus back? Because if you do a good hydrodissection, you will be able to, actually roll out the entire soft cataract. And then you barely need vacuum to...
I would be happy to explain, ma'am, if given some time. So this is not an NS1 or NS1 to 2, ma'am. Generally, I use it for NS2 and above. When we started off in private practice,
then it's not a soft cataract.
Yeah, so when we started off in private practice, I'm sure others have also felt, because I was training a lot of fellows at Narayana, the eating up of the epinucleus at the end of the surgery sometimes becomes a bit of an issue. And what I realized was going back to the basics and rotating the nucleus after dissection and delineation made it really easy for especially the younger surgeons or the surgeons who are starting off to clean the epinucleus at the end. And the delineation gave them a little bit of a safety net. Obviously, people like you, Chitra ma'am, and the others here, delineation and dissection doesn't really make much of a difference. But this was more aimed at people who are starting out in their career because it makes it slightly safer. Although slightly more cumbersome and longer, I agree, but it makes it slightly safer and slightly more convenient.
This would have been an excellent method for a posterior polar cataract.
Yes.
Is what came to my mind when you were doing that.
Yeah, but I wouldn't rotate a PP6.
Yeah.
The inner nucleus you can rotate.
Yeah, of course, once you show.
The only other thing is you should have showed everything very well. You should have enlarged your small rhexis. It was just a little too small. After the IOL implant, you could have enlarged it. One question to Dr. Ramurthy is, supposing because of the dialysis, if it had been a little more, a trifocal has not been, a premium IOL has not been placed. So, but it has already, what would you do for the multifocality in this kind of a situation? Would you think of doing a piggyback IOL, or would you think of a monovision in such a situation? Here, the area of dialysis was small. If it were a little larger.
You mean to say if we were forced to place a monofocal lens?
Yeah, yes. Yeah,
maybe I would just place a monofocal lens and counsel the patient as to what happened and make him accept the fact that he has to live with monofocality. But if it's a multifocal is already there in the other eye and insists on something, a piggyback lens later on is an option. And as you know, we always have this, as of now, we are having it, 3-piece multifocal intraocular lenses also in stock with us. And in case the capsular rhexis is intact, there are instances when we have gone ahead and done placed the lens in the sulcus and created an optic capture. But these lenses are no longer manufactured. So once we run out of stock, it's going to be a problem. I just want to add a word about this toric component that you brought in earlier. I think it's not just the shift of astigmatism that takes place over time. It's also the fact that 0.75 diopters of against the rule astigmatism is quite significant with a trifocal lens. And usually what we do here is our go-to formula is not Barrett Universal 2, but it's Barrett Toric Calculator. So whether we are using a Lenstar or a IOL Master 700 or a Tommy, we always put the patient first on a Barrett Toric Calculator. And depending upon the axis of astigmatism, very often you would find that with the 0.75 diopters of astigmatism, it might indicate a T3 or so. And in those cases, we'll go ahead and put a toric multifocal. Now we believe that the 2.2 or 2.4 millimeter incision that you made, the centroid value of the astigmatism is created is just about 0.1 diopters. And OCCI, I don't think when you don't introduce any instruments, anything, it's so easy to do it. So we were doing it, but hardly has any impact on the cylindrical component. So apart from the use of the panoptics, this is a case where I would definitely, with against the rule astigmatism, put the patient on the calculator, and if a T3 or so is indicated, go ahead and use that. If it's not the absolute number of the astigmatism, but it's also the axis which matters.
Yes, very true. And Anaga, if you have anything to ask, should I go on?
I was about to say the same thing, that I think instead of, and one diopter in today's date is really significant. So I would not even wait for one diopter.
It was
You just put
0.75,
it-
ma'am.
Yes,
Yes,
0.75.
no, but even if it is 0.75, you put it on the Barrett toric calculator or on the VARUN, whichever you have. And if it is showing a toric T2 or T3, we have
to implant.
Especially if it's a multifocal.
Multifocal, yes.
Can I add one point?
Yes, Dr. Bhavekar.
Dr. Kharbanda, while taking the cortex, once I purchase it in the IA cannula, I would move side to side and then pull it radially. That will decrease the chances of, it will loosen the cortex and it will decrease the chances of this accidental zonal dialysis.
Point noted, sir.
Yes.
I have a point to make. So many a times, anatomically, if you see the zonules, so you have anterior zonules, you have posterior zonules, and you have equatorial zonules. So there are these few patients who actually have the equatorial zonules which are weak, and whenever you're going there, you'll actually hold the equator and it will come into the bag itself. And these probably are the patients whom you should not kick yourself over, because they have a pre-existing equatorial dehiscence. And these are the patients in whom I would definitely go ahead and put in a CTR.
Yes.
So I don't think probably it was an accidental thing or a purposeful thing or intraoperative for that matter. It was a pre-existing thing, because the rest of the places wherein you did the IA, it did not come in that easily. So there probably was a pre-existing equatorial dehiscence, and that was allowing the bag to come into your aspiration port.
Probably, sir.
Varun, one more point. Your magnification was too low, I think. Was it a recording magnification?
It was the recording magnification, sir. I have
Recording
a remote system. It records on a
So
phone.
your microscope magnification was a little bigger.
Higher, sir. Yes.
Higher, yeah.
Because
Thank
if
you
you
very
get any
much.
higher,
The problem
field
was a
is
reflection of the drape. That was a
Yes,
problem.
sir.
You could
Yes.
not recognize.
That is what I considered,
Yeah.
but after hearing Dr. Abhijit's explanation, I want to believe that more than the fact that it was.
No,
That you could
that's
ever
true.
go wrong. Thank